Good afternoon. It's always a pleasure to receive our dearest colleagues from all over the world to share their research interest. And so we're going to have our best oral presentation number 2. I'm Dr. Moises Shapira, and our first researcher who's going to present his work is Dr. Tayane Abreu, who's going to talk about gero-transcendence, religiosity and life satisfaction, differences between the general public and religious individuals. Dr. Mrs. Tayane Abreu is a psychologist. She's a PhD student in geriatrics and gerontology at University of Aveiro and University of Porto. She's a gerontology of Aveiro University, and her research interests include cognitive interventions, well-being, and spirituality.
Hello, everybody. My name is Tayane. I'm presenting today the work entitled Gero-transcendence, Religiosity and Life Satisfaction, Differences Between the General Public and Religious Individuals. The authors of this work, it's myself, Professor Oscar Ribeiro, and Professor Lia Araújo. So here we have the gero-transcendence, that is an adaptive theory of aging, and it postulates about a mindset shift that occurs once one grows older. And this mindset shift will happen in 3 different dimensions: the cosmic dimension, meaning existential changes and connections with the universe; the coherence, that would mean self-confrontation, ego integrity; and solitude, that would mean change in many importance of relationship, increasing solitude time. So how can one be more gero-transcendent? We performed a scope review, and the findings were that life satisfaction had positive correlation with gero-transcendence, and also religiosity had positive correlation with gero-transcendence. Nevertheless, we also realized that some of these studies were assessing actually the religious affiliation instead of religiosity itself. So we decided to perform a study assessing religiosity through a validated instrument and comparing 2 different groups: the clergy and consecrated religious participants, which we call CCR, and the general public. So the purpose of this study is to add to the available knowledge on the association between these constructs by studying a specific subgroup of older adults, namely nuns and priests, by comparison with the general public. More specifically, we aim to analyze if there is a difference in gero-transcendence levels between the CCR group and non-CCR group. Also, to examine if religiousness is significantly related to gero-transcendence, and to verify if satisfaction with life is significantly related to gero-transcendence. So, in order to do that, we had the inclusion criteria: people with 55 years or older and 3 or more years of formal education. The exclusion criteria was they had to present no evidence of cognitive impairment. We had then 25 participants for the CCR group and 30 participants for the non-CCR group. We used a non-probability, convenience, and snowball sampling method. For data collection, we had the written consent and the social demographic questionnaire, the gero-transcendence scale, satisfaction with life scale, and the Duke University Religion Index, with 3 different types of religiosity: organized religiosity, non-organized, and the intrinsic religiosity. For data analysis, we had performed a Chi-square and students t-test for all socio-demographic data and instruments. Pearson's correlations were computed in order to determine levels of correlation between gero-transcendence, satisfaction with life, and religiosity, and also we used the SPSS. So here we have some results. We have the social demographic characteristics of participants, which we can see they are quite similar, except for years of education. We had more years of education for the CCR group. Also here we have the comparison between groups for the 3 scales we used, and we can see that the mean of all instruments were higher for the CCR group when comparing with the non-CCR group. They were all significant. We also have here the statistical correlation between instruments. And we noticed that the CCR group had higher levels of religiosity, life satisfaction, and gerotranscendence. So we thought about some reasons that this might happen. One of the reasons is that the CCR participants dedicate more time to reflect about transcendental and metaphysical issues, influencing their life events interpretation. This would have a deep connection with the coherence dimension, with the ego integrity process more specifically. We also think that this might happen because of the attitudes towards death. So since they are more connected with this transcendental and metaphysical issues, they also are more connected with their purpose in life and in the universe, and with less fear of death. So this part will be more connected to the cosmic dimension. We also believe that the religiosity has an important role here. So we think that they are actually religious, despite the non-CCR group. They were all religious affiliated, they were all Catholics, but the CCR group, they were more religious. So religious affiliation doesn't mean religiosity. And we found a positive correlation between religiosity and gerotranscendence. And we also can see this differentiation, which can differentiate our work from the previous works. We also noticed the higher satisfaction with life and a positive correlation with gerotranscendence. And this would mean the interpretation of life events, accepting life as it is. This would be a characteristic from these both constructs. So to conclude, we have a mutual influence, possibly through the cognitive components, by aligning feelings and thoughts in order to achieve the mindset shift. So the implications would be to clarify the relationship between constructs, to highlight the importance of religiosity and life satisfaction, and to help develop gerotranscendence practices based on religious and life satisfaction issues. We had a small sample, unfortunately, and we also want that future studies to perform longitudinal qualitative studies to verify the explanation above and how gerotranscendence is perceived. These are the references we used. And here is my email if someone needs to contact or has any doubts. Thank you very much.
Our second research is adoption of medical technology by elderly in Israel utilization, attitude, and association with disability. Who's going to present is Dr. Ayelet Berg-Warman. She's a senior researcher for aging at the Myers-Briggs Institute in Israel since 2000. Her primary research areas are elder abuse and neglect, active aging, supportive community programs, family caregivers, needs of aging, and aging and technology. Ayelet has a PhD in information system and was a lecturer in Tel Aviv University and at the Hebrew University of Jerusalem.
Thank you. Hi. I'll talk about adoption of medical technology by the older adults in Israel. But first of all, I want to thank my colleagues, Dr. Shirley Resnitsky and Yaniv Cohen from Myers JDC Brookdale Institute. Considering the great potential inherent in the use of remote technology for social and leisure, shopping, health, and daily life purposes, especially for those confined to their homes, the research objectives were formulated as examine connections between use of technology and background characteristics, focusing on level of disability, and learn about barriers and factors encouraging the use of technology. Quantitative and qualitative methods were incorporated in the study. The quantitative analysis includes a secondary analysis of studies conducted in 2018, 19, and 20 in Brookdale Institute. The survey among recipients of nursing home benefit included subjects where almost all of them are limited in functioning at one activity or another, while the other three are pilot program evaluations. The transgenerational community study is based on a representative sample of residents aged 65 and above in 6 neighborhoods where the pilot program was activated. The qualitative analysis included 7 focus groups. The youth-out model served as a theoretical model for explaining the use of technology. According to the model, attitudes and willingness to use have a strong influence on actual use of technology. However, attitudes towards technology are mainly influenced by age, perceived usefulness, and difficulty in using technology. The novelty in our study is the relationship with disability. In other words, how disabilities affect the use of technology. We used a unique definition of people with disability as confined to home and made comparisons between them and the others. The slide shows greater use among people without disability, independent, compared to those with disability in all 3 studies. This slide shows the uses that are made of technology by people with disability and independent people. The uses were divided into 3 categories: medical, product and service purchasing, and the third is for leisure and social purposes. First, we can see the widespread use for social and leisure purposes stands out. Second, the use for medical services is very low among people with disability, even though they have greater needs and the remote technology can help them a lot. Similarly, online shopping and payments that those with disability can benefit greatly from, precisely here, the use is minimal. This slide shows the findings regarding attitudes of recipients of nursing home care towards technology in general and towards medical technology. General attitudes are, for example, the internet is an effective tool for getting information. I have a positive opinion about the use of technology, etc. Medical technology includes looking for health information and using technology for home care or for improving health. Most attitudes are positive, and they are more positive among the independent. The 2 negative attitudes are at the bottom of the slide, and they are higher among people with disability. To neutralize cross connections between the various variables that can affect the actual use of technology, we ran a 2-stage logistic regression. The dependent variable is the medical technology use. The explanatory variables are the background variables in the first stage. In the second stage, we added the attitudes. Lower age connects with higher age. And we see that independent people have a 25-fold chance of using technology compared to those with disability. The interaction of old age and disability shows that those who are both older and disabled will use technology even less. The more educated a person is, and in a higher economic status, the more inclined he is to use technology. In this slide, the attitudes were added to the model. Factor analysis revealed 2 factors regarding the set of questions about attitudes. Attitudes towards technology in general and towards medical technology. They were added to the model as dichotomic variables, positive attitudes versus the negative. This slide shows that positive attitudes have a very significant positive effect on use beyond background characteristics. This means that at any age, a person's attitudes towards technology are the most influential on using it. From the focus groups, we deepened our understanding about barriers and factors that can promote use. Barriers were fear of failure and embarrassment from grandchildren, for example, physical difficulties like shaking fingers, difficulty seeing, fear of invasion of privacy and cost of infrastructure. Promoting factors were mainly family members, recognition of benefits and causes. To sum up, the novelty of our study is the negative association between functional disability and use of technology. And combined with old age, the chances of using technology are extremely low, despite the potential assistances they could benefit from it. We have found that positive attitudes towards technology and medical technology in particular increase the likelihood of using it beyond demographic characteristics and functioning. So we recommend to raise awareness of the benefits of using technology, train family members and caregivers as agents of using technology, deliver lessons tailored to this population, and improve the application interfaces for the older population. Thank you.
Our third research is opening a new horizon of using a companion in everyday life, service satisfaction for AI care, calling community for the elderly. A speaker is Dr. Ra Kun Ho. Dr. Kun Ho is a director of healthcare lab at Naver. Naver is a #1 search engine company similar to Google in Korea. Naver leads AI technology today, and he will present the interesting research.
Hello, this is KH Ra from Korea, Naver Care. Today, I'll be presenting about opening a new horizon of using AI companion in everyday life, a service satisfaction for AI care call in community for the elderly in Korea. Elderly loneliness and social isolation is a big problem everywhere, and we developed AI care call, an AI engine developed to solve worker shortage. AI care call was developed during the COVID situation. March 9th, 2020, some 2 years ago, we started to AI care call service in Seongnam City in Korea. What you see in the slide is we surveyed more than 1,300,000 people and made 6,000 calls per day to those people who have an exposure to COVID. Does he have a fever? Does she have any URI symptoms? And we did until January this year. With this experience, we had a automatic AI call and conversation with the public welfare centers for the elderly people. So purpose of the study has been to evaluate the level of satisfaction for AI care call during its trial service held for the elderly, thereby suggest the possibility of its widespread use and application. We did the proof of concept test in Haeundae Welfare Center, which is located in the second largest city in Korea, Busan. Way it designed was it was a 1-month study with 1,000 citizens, and we made 1 call every 2 weeks. And the average age of the patients were 71-year-old, and there were male and female ratio of 4 to 6. How we developed this engine was using a supercomputer called a hyperclova with the GPT-3 engine in Korean. We stored all the knowledge we gathered through the Naver website, which is a Korean Google. And we did a machine learning and supercomputation of 1,000 times of these scenarios. Therefore, we could improve our engine from rule-based chatbot on the left, and we can do a free talking with the AI computer-generated care call. For instance, we can talk about their conditions, insomnia, their eating, and we can actually stop with the AI engine when the senior citizens will not like to speak. The results were astonishing. 95% of the participants used it, and 92% of them found the service recommendable to other senior citizens. 94.9% were willing to use this service afterwards, and they said it is better than 7 points out of the scale of 10. Whether the conversation speed was adequate, they said it was a very interesting, and 90% and 100% of the participants answered yes, respectively. 89% of the participants were satisfied with AI care call, and they felt relieved after receiving the call. So this is our plan for this service in South Korea. Starting with the pilot service for the safety and emotional care through hyperclova-generated free conversation, we try to improve into monitoring calls that change every time, reflect their health status and lifestyle. So we are not going to ask the same questions over and over again, whether we could modify, such as a human person, social worker, is making the actual calls. At the last phase, we'd like to do a emotional care with elderly specific talkers who can talk freely with the topic. So it feels like you're talking to a real human social worker who understands you because they memorize what happened in the previous conversations. So this is a conclusion. This study identifies AI care call as a potential companion to the elderly, capable of everyday conversations. Further research is required on the long-term effects of the AI care call and conversation quality to achieve human-like AI. Thank you very much.
Our fourth researcher is the impact of lifestyle on life expectancy. Who benefits more, healthier or less healthy ones with chronic disease, based on a prospective MU cohort? Our speaker is Mrs. Shu Lee. Mrs. Shu Lee is a PhD student in epidemiology and health statistics at Zhejiang University. Dr. Shu got her MD and MS at nursing. Her research of interest includes behavior intervention, community health, and non-communicable disease management. Her major focus of investigation is the effect of lifestyle and adapting lifestyle interventions for groups who suffer from chronic diseases to enhance in their outcomes.
Good morning and good evening, everyone. I'm Shu Li, a doctoral student in Zhejiang University. It's my honor to speak here, and I'm very glad to share our research about the impact of lifestyle factors on life expectancy. We want to know who benefits more, healthier people or less healthy ones with chronic diseases. Okay, then I will turn to the next slide. There are 4 parts of my presentation. Non-communicable diseases are the commonest cause of death worldwide. WHO urged people to take actions to reduce the burden of NCDs and set priorities to strategically utilize available resources to improve NCD outcomes by reducing population exposure to behavior risk factors. Next slide. Even the benefits of healthy lifestyle are commonly recognized. However, little is known as to the degree of healthy lifestyle could impact those with and without NCDs. In other words, which population should be primarily concerned about lifestyle promotion, and how much benefits could be gained for those with established NCD burden. This study, we examined the associations of healthy lifestyle factors with deaths by NCD burden. Next slide. We use data from the MJ cohort study, which has enrolled around 600,000 Taiwanese individuals since 1994. The baseline information from 1996 to 2006 was collected, and the participant follow-up to December 2011. We excluded participants less than 18 years old or diseases within the 2 follow-up years. At the end of follow-up, 50,642 deaths were recorded. Next slide. We selected 5 commonly known lifestyle factors, including smoking, alcohol consumption, physical activity, body weight, and diet. We calculated the total number of healthy lifestyle factors and classified the participants into 4 lifestyle category groups. Then we quantify the NCD burden by a weighted NCD score. Divide the participants into 3 groups: light, medium, and heavy. Higher level of NCD burden indicating higher levels of death risk. Firstly, we put the 6 chronic diseases and confounding factors into a model with all-cause mortality as the outcome. Then we divide each disease or markers regression coefficient by the variable of age. Then round the risk points to the nearest integers and sum up. So we arrive at personalized NCD score. Next slide. Cox proportional hazard models were used to evaluate the individual and combined associations adjusted for age, education, occupation, marriage. Hazard ratios were calculated. Next slide. This table presented the associations of the number of healthy lifestyle factors with all-cause mortality by NCD burden. Generally, adhering to more healthy lifestyle factors was associated with reduced risk in the dose-response manner of death for both men and women. In men and women with heavy NCD burden, having more than 4 healthy lifestyle factors was associated with 44% and 48% risk reduction in all-cause mortality, in contrast to smaller reductions in those with light NCD burden. Individuals with heavier NCD burden could benefit more from lifestyle modification. Next slide. This figure shows the joint associations of the healthy lifestyle and NCD burden with all-cause mortality. When all groups were compared with the group with less than one healthy lifestyle factor and the light NCD burden, the risk for individuals with heavy NCD burden were increased by 132% and 104% for both men and women. When the number of healthy lifestyle factors maximized, the increased risk by heavy NCD burden was attenuated by 88% for men and 67% for women. Next slide. One of the most significant findings of this study is shown on the picture. We found that the poorer one's health status, the more years of life could be gained when maximizing lifestyle benefits. For example, at the age of 30 years, 10 years of life expectancy was gained from having more than 4 healthy lifestyle factors in participants with the heaviest NCD burden, as compared to less than 5 years in participants without NCD burden. Mechanism underpin disproportional healthy lifestyle-related benefits in NCD burden groups remain unclear. We assume that the possible explanation is a positive synthesis between lifestyle and NCD therapy. So the benefits of combined healthy lifestyle are particularly pronounced among those in poor health. Next slide. In conclusions, we found that the heavier one's NCD burden, the greater the benefits of maximizing healthy lifestyle in reducing mortality risk. The heavier one's NCD burden, the more benefits they could be gained from healthy lifestyle factors. Okay, this is the end of the presentation. It's my pleasure to share my study with you. Thanks for your kind attention. Any questions are welcome. Thank you very much.
Our fifth researcher who's going to present is Dr. Chang Lu. He's going to talk about preparation for future care provision among Chinese adult children, scale validation and policy implications. Dr. Liu Qing as a postdoctoral fellow at the Institute of Active Aging and Department of Applied Social Sciences of the Hong Kong Polytechnic University. She has been active in the field of social gerontology with research interests in intergenerational relationships, caregiver stress and burden, and care planning in aging families.
Hello, everyone. I'm Liu Chang from Hong Kong Polytechnic University. My presentation today is about preparation for future care provision among Chinese adult children, scale validation, and policy implications. As China is experiencing extremely fast population aging, the elder care has become a crucial social concern. Care planning as a form of proactive coping may buffer adult children's potential caregiving stress and better prepare them for future care provision. As suggested by the Preparation for Future Care Needs model, care planning comprises 5 different domains, including awareness or avoidance of future care needs, information gathering, decision-making, and concrete planning. Dr. Sorensen and her colleagues also developed a 15-item scale to measure older adults' care planning behaviors in the 5 different domains. However, care planning still remains insufficiently studied among Chinese adult children, partially due to a lack of validated scale. This study aims to translate, adapt, and validate a Chinese version of the 15-item care planning scale for adult children, and to assess the levels and characteristics of their care planning behaviors. This study comprises 2 phases. In the first phase, I conducted pilot interviews with 20 Chinese adult children to adapt the scale. Some items revisions were made. In phase 2, a self-administered questionnaire survey was conducted in Shenzhen, China, with 530 adult children aged between 26 and 40. I measured their age, gender, self-perceived SES, their parents' age, and their care planning behaviors in 5 different domains. For data analysis, besides descriptive analysis, I conducted item analysis, then EFA and CFA to test structural validity of the scale. The non-group's validity and internal consistency reliability were also tested. Here also lists the model fit indices. Here are the characteristics of the sample. After item analysis, the item 10 of the scale was deleted because of its low corrected item total correlation. So EFA was conducted with 14 items with the random half of the sample, and 4 factors with eigenvalues larger than 1 emerged. In this table, we can see that the EFA yielded a 4-factor pattern. The CFA results with the other random half of the sample supported the 4-factor model. In the new model, the items of the awareness domain and decision-making domains loaded together, and we named the new factor as awareness decision domain. Because the level of care planning may be related to parents' potential care needs and adult children's levels of resources, the known group's validity was tested by comparing the total scale scores of adult children with different SES and their parents' different age. The results supported the known group's validity. Lastly, the Cronbach's alpha for the whole sample is 0.814, and the values for the 4 subscales were all above 0.6, indicating satisfactory levels of internal consistency. Moreover, the total score of care planning was 42.65 out of 70, representing a moderate level of care planning. This study is the first to adapt and validate the care planning scale for Chinese adult children and assess their care planning behaviors in different domains. The new factor of awareness decision indicated that for Chinese adult children, the awareness of their parents' future care needs and decision-making are intertwined components and indicated the implicit decision-making strategies in Chinese families. This scale can be used to identify adult children who are less prepared for future care provision to determine the domains of the care planning that an adult child is least prepared. By using it, the government and service providers could develop care planning, training programs, and services for adult children to improve their care planning abilities. It's all about my presentation today. Thank you very much for listening.
Our 6th researcher who's going to present is Dr. Lin Quach. The title is The Benefits of Care, Treated HIV Infection and Health-Related Quality of Life Among Older People in Uganda. Dr. Lin Quach is a PhD, an MD, and a gerontologist at the research scientist at the Medical Practice Evaluation at MGH and an assistant professor at the Department of Gerontology of Massachusetts, Boston. Her research interests focus on the social determinants of health, specifically how social disconnection patterns relate to mental health, physical function, and quality of life in older adults. Her work seems to understand the unique roles social isolation, network characteristics, and social support play in health outcomes in older adults, including people living with HIV, AIDS, and both in the United States and globally.
Hi, everyone. Thank you for the opportunity to be with you today. On behalf of the Uganda Aging Study Team, I would like to present our study with title, The Benefits of Care Treated HIV Infections and Health-Related Quality of Life Among Older People in Uganda. Health-related quality of life is an important indicator of the well-being of older people with chronic health conditions. With access to treatment, people with HIV have life expectancy approaching that of people uninfected with HIV. According to the data come from the Global North, you can see from the figure that health-related quality of life among people with HIV in red remains reduced compared to HIV-negative populations in blue in all 5 domains. What did we know about the relationship between HIV and health-related quality of life in sub-Saharan Africa? First, there is a big number of older people with HIV in sub-Saharan Africa. Currently, 70% of 37 million people living with HIV worldwide live in sub-Saharan Africa, and more than half of them is over 50 years of age. Second, the scale up of ART treatment from PEPFAR or other HIV intervention program is usually accompanied by additional interventions such as peer support, vocational training, clean water, and unique access to general health care. And people in the region may have a strong resiliencies and social support. Based on what we learned from the literature, we have two aims for this study. First, we measure the association between treated HIV and health-related quality of life among older people. The hypothesis is that people with HIV on ART have a similar HIV health-related quality of life compared to HIV-negative individuals. The second aim is to investigate how gender and age impact the association between HIV and health-related quality of life. The hypothesis is that being female or increased age can modify this association. In this study, we have the sample size of 600 participants. We analyze the data. The group of people living with HIV having at least 49 years old in ambulatory care. They are on ART for at least 3 years. The control group was recruited based on age and the sex similarity to the HIV group. They live in the clinic catchment area. Health-related quality of life as the outcome measured in 3 different ways. First, self-reported health status. Second, the utility index, using time trade-off variation from Zimbabwe, and third, the subscales, including mobility, self-care, usual activities, pain, and anxiety or depression. The exposure is HIV zero status. For statistical approach, all the models adjusted for socioeconomics, education, marital status, alcohol consumption, and comorbidity. This figure shows the characteristics of study populations by HIV status compared to people with HIV in red versus the people without HIV in blue. There are no differences in terms of age, gender, education, and comorbidity, except for marital status. People with HIV have a lower prevalence of living with spouses or partners. This figure shows people with HIV in red had a slightly higher score of health-related quality of life measured by self-reported health or utility score. For adjusted models, people living with HIV have a higher self-reported health by 7 score than people without HIV. Again, people with HIV have a higher utility index by 0.05 compared to people without HIV. For subscale, people with HIV has report higher health-related quality of life for the self-care by 2 times or 1.8 times for pains or discomfort dimension compared to people without HIV infection after adjusting for the confounders. We found that the relationship between HIV and health-related quality of life differ by gender. The highlighted red on the right side figure reflects that HIV status is associated with a better self-care domains among females, but not among males. On the left figure, you can see the highlighted blue reflects that HIV status is associated with not having problem with pain or discomfort, or having problems with anxiety or depression domains among males but not females. Age did not modify the relationship between HIV and health-related quality of life. In conclusion, older people with HIV taking ART report equal or better health-related quality of life than age and sex similar people without HIV. The results in contrast to the data from Global North, where people with HIV report lower health-related quality of life. Future work needed to understand what accounts for these effects. Because of unique access to primary care supported by BEFA, or because of resiliencies or access to strong social support network, or the combination of other factors. As gender modifies the relationship between HIV and health-related quality of life, female and males may need to have different approaches to managing chronic health conditions to improve their quality of life. I would like to acknowledge the funding agency research participants in Uganda and my collaborators. Thank you for your attention.
Our seventh research work is telehealth in developing nation. Are Malaysian early ready? By Dr. Shobha Sharma. Dr. Shobha Sharma is a senior lecturer in speech sciences at University of Kebagawan in Malaysia. She has a master's degree in adult body disorders and in adult swallowing disorders, and a PhD in telerehabilitation. She's an active specialist clinic in her university at Kuala Lumpur General Hospital and the Malaysian Parkinson's Disease Association, and also run student clinics at several locations.
Thank you very much for that kind introduction. Today, I present our research that was carried out in the midst of the pandemic as part of a student project required to graduate as a qualified speech language therapist from my university. So just a quick geography lesson. Malaysia is a smallish country in Southeast Asia with a total land area of 329,000 square kilometers. That translates to about 127,000 square miles. And it is the 66th largest country in the world in terms of area. So you can see how small we are compared to the rest of the countries. The largest group of Malaysians consist of three main races, namely the Malays, the Indians, and the Chinese. So this is how we look as a population. And if we divide and show you this on a table, this is how it looks like. So the majority are the Bumiputras, or the Malays, or the natives, followed by the Chinese, Indians, and others. So a vast majority of Malaysian population is in the working age group, as you can see here, but there's a steady annual increase of those who are 65 years and older. This slide, of course, shows you that this group of individual comprises people of various abilities and backgrounds. So we have those who are in the elderly and frail group, those who live in community care homes, one of who became the prime minister for a second time when he was 92 years old, and he's still very cognitively intact and physically able, and also those who actually stay in their own homes among the community and are comfortable using technology. So irrespective of where they stay or how independent they actually are, access to healthcare is very, very important and certainly vital. So Malaysia can actually boast about a very efficient and widespread healthcare service that is either provided by the government on a heavily subsidized rate or by private hospitals and clinics. So during the COVID-19 pandemic, however, the hospitals were actually bursting their maximum capacities and all non-essential healthcare services were halted. In addition, the movement control order was enforced in Malaysia, and all travel outside of a 10-kilometer radius was actually banned. So one potential, if it was indeed possible, was to provide services such as rehabilitation or mental health services or even basic medical services via telehealth. But obviously a telehealth service would require a mobile device to avail. So as you can see here, there has been a very steady increase in the use of smartphones in Malaysia. Currently, there are approximately 29.46 million people in Malaysia who are smartphone users. And that's saying that almost everyone over the age of 15 years owns a smartphone. But if that is true, then the access to healthcare could potentially be provided via telehealth, at least for the elderly population, right? So the objectives of the current research was to explore the needs of older adults and inquire about their perceptions, opinions, and suggestions on the implementation of telehealth services in Malaysia. The research participants were older adults aged 60 years and over, able to read and converse either in English or Malay language, which is the national language, and willing to share their perceptions or experiences of telehealth. All participants then provided online consent using a prepared Google form sent to them. 4 semi-structured focus group discussions, or FGDs, were held. Discussions were on 4 separate days, lasting 1 hour each. Each FGD had 3 to 6 participants. Discussions were in Malay or English, and also all of them were audio and video recorded so that we could transcribe the discussions at a later time. The discussions used semi-structured questions and explored participants' knowledge of telehealth, experience in using telehealth services, perceptions of telehealth, and barriers to the service that may be provided to them. A total of 16 participants were involved, comprising 8 males and 8 females. All participants had completed at least a high school degree, with 5 of them holding bachelor's degrees. Most of the participants were retirees. All participants owned at least a smartphone, while 7 of them also had access to a computer. All of them, irrespective of age and backgrounds, had access to the internet. Transcriptions of the discussions were analyzed using the Braun and Clark's phases of the thematic analysis model by Noel et al. 2017, and also the NVivo software. So this is the coding tree that arose from the data analysis, and 2 themes arose. The first being trust and uncertainty. As you can see here, several words have stood out from the participant statements regarding the knowledge of telehealth, revealing that there is some knowledge present. Not everyone knows everything about it, but there is some knowledge present. The comments, however, were only from 2 participants. So knowledge of telehealth was indeed limited. Some of the other 14 participants had some positive perceptions of telehealth, including the ease of access to services and reduction of travel time, while 1 participant reported the possibility of a preference to face-to-face services. Participant N here felt that in order to be effective, telehealth would have to be a service that provided health information catering to the interests and needs of the public. Participant C also had positive perceptions regarding telehealth and felt that since everyone owned a gadget and had internet access, that telehealth would indeed be more effective. Participants J and G were somewhat unsure about telehealth services. The second theme to arise was that of challenges and facilitators. The perceived barriers included a lack of internet coverage in the rural areas of Malaysia and not having a telecommunication device to utilize telehealth services. Participants I and A pointed out that the awareness and acceptance of telehealth was important to a successful implementation. Participants A and J additionally felt that some individuals may not know how to use a smartphone for telehealth and may not necessarily accept this modality to access healthcare. Participant B reported that he would prefer the conventional face-to-face consultation over that of a telehealth service and emphasized the possible reduced understanding and absence of body language in a telehealth consultation. So in summary, the present research revealed that the digital literacy and knowledge of telehealth can indeed influence the perceptions and acceptance of telehealth by older adults. So one of the reasons why this could be is that the entire focus group discussion was carried out online versus a face-to-face environment. Technical issues were faced, and some of them, as a result, did not provide sufficient responses for us to analyze. And therefore, larger sample sizes in diverse age groups are definitely needed. So in closing, telehealth services will be a big part of healthcare going forward, irrespective of the pandemic or otherwise. We should all attempt to utilize this modality due to its limitless potentials. Healthcare, at least in the form of telehealth, is actually only just a click away. These are my references. I thank you.
Our 8th research job is In Search of Living Well with Dementia, a qualitative study by Dr. Gili Yaron. She's a philosopher by training, a PhD in medical humanities at Maastricht University at the Netherlands, and currently is a senior researcher at the research group Living Well with Dementia of Windesheim University of Applied Sciences at the Netherlands.
Hi, my name is Gili Yaron, and I work as a senior researcher at Windesheim University for Applied Sciences in the Netherlands. And I'm presenting on our research project into what it means to live well with dementia. Now, first some context. Dementia is on the rise and there is currently no cure. And in research and policy, we see the dominance of the so-called biomedical approach. This means that there is a focus on diagnosis, symptoms, medication, and relatively little attention to social impact of dementia. Now, within this field, we also see what is called a tragedy discourse, which is a collection of images and stories stressing decline, suffering, passive victimhood in dementia. However, that is not the whole story. In recent years, we see the rise of the psychosocial approach, which aims to support meaningfulness, participation, and well-being in dementia care. And within this, we see the emergence of a new concept, namely living well with dementia. However, studies into this concept are mostly quantitative and focus on predicting the impact of dementia on the capacity to live well. Now, interestingly, these quantitative studies are also mostly approaching living well derivatively, meaning that they use existing measures such as quality of life, life satisfaction, and well-being to understand living well. And also interestingly is that implicitly, these studies equate living well with empowerment and positivity. All the while, the inside perspective of stakeholders remains uncharted. So to address this insider perspective, our study asks the question, what does living well with dementia mean from the insider's perspective? And in order to answer this question, we have followed a qualitative research design, which enables us to focus on stakeholders' own lived experiences in the context of everyday life. Now, using the data, we have performed thematic analysis, and we have come up with 3 themes that help us understand people's own perspective on living well with dementia. Our first theme is shaping various goods in everyday life, then interwoven lives, tensions within, and then constantly seeking attunement in a complex situation. And I'm going to go by them one by one. So theme 1 is about the personal meaning of living well. Now, participants indicate that living well is highly subjective. When asked about it, they give concrete examples such as walking in the dunes, enjoying a healthy and tasty meal, living in a pleasant and safe house. And interestingly, and this participant says, for instance, that I can ride my bike and drive a car. I can go where I wish. If I want to, I can visit my sister-in-law. So this is an example of what they consider living well. Now, interestingly, participants also say that there is no formula for living well because that's a highly subjective thing. It's very personal. However, this is affected by differences between people, differences in character, but also differences in resources such as money or help. And yes, of course, dementia undermines the ability to live well, but still there is much to be done to ensure that people with dementia still are able to live well. And what is to be done has to do with conditions such as access to care and support, accessible provisions, and clear information, but also personal attitudes, such as focusing on what is still possible, recognizing challenges and negative emotions without downplaying them, but also having a dialogue on the boundaries of living well, such as a transition to a home or death. And very importantly, personal attitude is about actively seeking out moments of pleasure and positivity. As one participant says, what I do find important is that you dwell on those beautiful moments, like a Mother's Day, birthday, Christmas, experience them much more intensely, and also record them with pictures or rituals. Now, the second theme is about tensions within the person with dementia and between various people in their network. Now, first, the person's identity changes due to dementia. And the question is, who is the real person? There is the past identity with old habits, preferences, roles, relationships, such as one participant says, my mother can't undertake things herself. So I'll be looking for what is good for her and what would she like. I know she loves animals and that she liked going to watch the goats at the petting zoo. So I just assume that's still the case. This woman tries to attune with the past identity of her mother. But people change with dementia, and they have different capacities, experiences, behaviors, preferences. For instance, some people who used to be vegetarians start eating meat, or they become very playful. And who do you attune with? The person that was or the person that becomes? Now, secondly, we also see that there is differences in the network surrounding the person with dementia, because people in the network have different hats, different roles, and these can conflict. As one participant says, you see marriages break down. It's quite a change. They are no longer partners. He's the care receiver and I am the care provider. You have a certain balance before and you were equal. And at a certain point that just diminishes. Now to the third theme. This theme is about how stakeholders constantly seek attunement in a complex situation. Now, first, participants indicate that dementia is about living in a very complicated puzzle because change is the only constant, and they need to navigate a very complex landscape of formal and informal care and support. So this calls for continuous calibration and coordination. Now, calibration and coordination are about working to find attunement. And this is about signaling tensions, trying what works and what doesn't work, but it also involves following and leading. Following is about inviting the other person by explaining or tempting. As one participant says, this woman is totally losing her overview of things now. And you try to put things to rights, but she finds it hard to let go. You need to do things in her pace. And I see from 10 kilometers off, she can do a lot, but also a lot not. So yeah, that's difficult, but you have to let somebody muck about for a while and leave them be. This is about following. But there is also leading involved, and that's moving with the other, going along, tempting them. So one participant says, we used to make a running gag out of taking a shower. My father, he really didn't feel like taking a shower. But when I'd say, Dad, you don't want to become a stinky old man, do you? And then he would take that shower. So to conclude, living well is actually a verb because living well is dynamic and ongoing search for the good. And it involves interactions with various others. And it's in that sense, a communal search for attunement and balance. But this is not only about positivity and empowerment, it includes the entire spectrum of human experience, like loss, frustration, and despair, challenges and limitations. And these must be recognized instead of being played down. Thank you.
Our ninth research job is by Dr. Rogério Vieira. The title is The Pandemic Impact on Geriatric Age. Dr. Vieira is an intern physician of psychiatry at the Barreiro Montijo Hospital Center. He has a postgraduate in family and couple therapy from CRIAP Institute, and he's an integrated master in medicine faculty of medicine at the University of Lisbon. She had a degree in nursing University of the Azores.
Hello, my name is Rogério Vieira, and my presentation will be about the impact of the pandemic on the geriatric population. Here you can see a graphic with the distribution of ages and gender of COVID cases. Although the median age of COVID cases is 51, fatal event rates are higher for those over 80 years of age, 5 times higher than the global average. The most frequent chronic comorbidities were hypertension, diabetes, cardiopulmonary diseases. Most patients will have died of multiple organ failure. The symptomatology of disease is reported to be more severe and longer in time. In elderly, individuals require higher monitoring and greater number of medical interventions, as you can see here. Mortality of 83.7% at ages higher than 70 years old, mortality of 16.2% at ages higher than 69 years old, and comorbidities in 32 to 51 of the cases, the ones I told you before. Median age of individuals infected with SARS-CoV-2 is 65.8 years old. As you can see here, the graphic of COVID-19 and geriatric population, the risk factors, the need for special care during the pandemic, development of efficient and safe vaccines, mitigations, and strategies. The risk factors. Age eventually alters the body response to lung infections. The angiotensin converter enzyme expresses in myocytes, endothelial, and pulmonary epithelium cells acts as a receptor for the virus. Serious complications of these infections at these ages, like SARS, multi-organic dysfunction and death, especially in those who already have comorbidity. Complications secondary to health care includes DVT, sepsis associated with catheter, pressure ulcers, fails, and delirium. As you can see here, the percent of some of the risk factors. Next, I will talk you about some of the importances of these risk factors like loneliness, inequalities, physical and psychological symptomatology, cognitive deteriorations, and the future. Loneliness and physical contact. These individuals feel very put aside because their age conditions, physical contact, they have more associated comorbidity, and for this reason, the care to be taken end up being more rigid, something they feel is not true at younger ages. Some older people even say that they are afraid to attend other spaces than their homes because they are not sure that others comply with the rules and rules of against COVID-19. Nevertheless, some elderly use social distancing as an active form of coping and can also be considered a strategy focusing on emotions as suggested by some authors. It should not be noted that although many elderly people may even have technological resources so that they can communicate with their families, many of them cannot understand how they work. It is important to invest in the technological training of the elderly since, in addition to bringing them closer to their loved ones, it also allows them to have access to medical knowledge, resources, bureaucratic resources, and other stuff. The long-term focus on governments should be programs that increase access to technologies, thereby giving this population the opportunity to learn how to use them. Foster homes and community centers should also take advantage of digital literacy programs. It is important that this age group has access to technology because the group between 20 and 44 years old is the one who uses telemedicine the most. It is the elderly, which is understood to be over 65 years old, who have a higher number of years of going to health centers and hospital. giving priority to sending pension checks to the home and not to the post office. The elderly surveyed say that other people have an overprotection of them, both in family and institutional environment, particularly in those over 70 years of age, which ends up causing feelings of discrimination in them. To prevent this from happening, one should actively seek to involve these individuals in events that directly affect them. Technological access. An article advocates the division of technological access in these 4 levels. With this model, we can divide into: the person does not have access to all the material. Isn't the person motivated enough to use the technologies to their advantage? Does the person have enough training skills to work with the technological material? The person does not have the ability to use the technologies for his advantage? The authors conclude that in the geriatric population of Western countries, they have less access to technology compared to young people, but also use of the technology they have more limitedly. Although basic access to technology is limited, especially in poorer communities, internet access rates are generally high, especially in Western countries. Studies show that the associated costs or capabilities play a very small role in why older people use technology little. By research done by several authors, the main factor by which they use technological access less is even due to reduced motivational access and lack of general skills. The selection of these individuals, as you can see in this survey, must be based on an age over 67 years old, taking into account the retirement age in Spain as well in other countries of the European Union. During phase 1 of confinement, where a time limit was established for staying abroad, telephone contact was established with 20 individuals over the age of 67 years old. 6 of the interviewees answered at the beginning of the intermediate phase of confinement, in which there was no longer a limitation of time to stay abroad, but in which those over 70 years of age were advised to respect a restricted schedule. After this data collection, the snowball technique was used, in which participants were asked to suggest people who did not belong to the center or had different characteristics of them. The interviews were based on topics such as impacts of confinement on their day-to-day life, on their relationships, on their perception of the image of the elderly, and what personal attitude and expectations was able to better bring together the individual perspectives of the participants. They receive and make frequent calls, particularly the elderly who live alone. However, it should be noted that the people included in this table are from medium-high socioeconomic strata, with technological resources and adaptability to new technologies and social networks. There seems to be little difference between the elderly who live alone and those who live with them. With regard to satisfaction they feel about the contact maintained with other people. This goes against what is observed during confinement, with 30% of people reporting feelings of loneliness, and being one of the condition factors of this loneliness, the fact that they are spending the confinement alone, a justification that is given related to the fact that the elderly who most resent being those who previously lived with family. Limitations of the study to be taken into account are on representation of a population with frequent cultural participation or a good social network. We cannot generalize the findings for people over 67 years old of age. Conclusion factors to be taken into account in future studies are levels of social participation of knowledge, gender, educational level, and housing conditions as well. For inequalities, this financial inequality can also condition the technological access of these elderly. Governments should focus on supporting initiatives to purchase technology resources to address this. Always take into account the academic degree and literacy levels so that trainings can be better adapted. Governments must ensure that the young people in financial inequality have access to food, water, essential goods, services, and basic health care. Physical and psychological symptomatology. A more depressed mood can lead to the elderly neglecting themselves, which scans by their appearance, feeding, outgoing, or cleaning the dwelling where they reside. These individuals report a higher degree of anxiety due to the cessation of routines that previously brought them pleasure, accompanied by all the information about COVID-19 situation makes them feel worry, fear, or uncertainty. This higher degree of anxiety can be justified by the heterogeneity of population as well as a greater ability to use strategies in the face of adverse situations. They seem to focus more on positive aspects of the situation and have more emotional skills. Symptoms of the SARS-CoV-2 disease. In addition to dry cough, other respiratory symptoms include dyspnea, sore throat, and rhinorrhea. The most common symptoms of infection is fever. However, in a study involving 18 patients over 60 years old of age with COVID-19 infection, only 77.7% had fever, suggesting that SARS-CoV-2 infection is not necessarily accompanied by fever, although the fever clear indicates that an infection is in progress. There is a higher frequency of this infection in females at older ages. Cognitive deterioration. In relation to elderly with a previous diagnosis of dementia, an acceleration of cognitive deterioration perceived by living people affects their memory, sleep, mood, and behavior, as is described. A study conducted by the Alzheimer's Society describes that 82% of individuals with dementia had an increased in dementia symptoms during quarantine, including memory loss, difficulty concentrating, agitation, or restlessness. Studies indicate that physical exercise, even in mild, moderate amounts, can have a significant positive effect on the cognitive function of older people, especially those with documented cognitive deterioration or neuropsychiatric diseases. The loss of socialization, increased psychological tension, general mental problems, and decreased physical exercise can have significant negative effects on the geriatric population. Although confinements are somehow temporary, the effects on the population appears to be long-term and can bring significant risks in the quality of life of these patients in future years. So, future. Fear of a new confinement, particularly if winter is present. As you know, the rough quality of the weather. 2 in 5 anticipate worse quality of life in the next 6 months. 25% of the elderly people over 70 years old described an uncertainty as to when their lives will be returned to normal. 31% think it will take up to 1 year for their life to return to normal, and 9% think their lives won't go back to normal. In conclusions, it must be ensured that the geriatric population can establish social contact, secure family ties, and invest in the technological training of the elderly as the resilient and skilled individuals they are. Thank you for your attention.
Thank you very much to all the researchers. And now we have a few minutes for questions.
Good afternoon and good night for some of you. It was the very, very interesting presentations. The first question is for Dr. Shun Lee. Yes, who benefits for better lifestyle? The one who are healthier ones and the one who are more frail? What was your question when you started thinking about this? What was your first thought? And what did it differ when you just finished the study or not?
Sorry, can you repeat the questions?
What is the difference between what you first started the study and when you finished and your conclusions? Was it different, or the answer you choose or the answer you found was the same one?
I started the study from the February this year, and almost finished the study about May. I also tested the same questions as to the cancer incidence, and I found the same conclusions. That is, people with heavier and sleep burdens could benefit more from the combined health lifestyles. From these studies, we strongly advocate to combine, to take the healthy behaviors, especially the combined healthy behaviors through population-wide methods, and more incentive efforts required to target people with poor health conditions and improve their outcomes. And I can't hear you clearly about another question. I'm so sorry.
There's no problem. The second question was for Dr. Gil Yaron. The question is regarding living well with dementia, and as you told, it's kind of many of us who work with dementia, we have a problem with people without language. What did you find in those people who can't just communicate how they feel, and what happens with all the people who are around? What is the meaning of language in that type of patients, in that stage of patients?
Thank you. This is a very good question, particularly in the later stage of dementia. The people that we interviewed, there were some family caretakers who also took care of people in later stage dementia who could no longer communicate. And what they indicated was that being a part of a family in which things are going on, grandchildren singing for their grandparents, being a part of the hustle and bustle of the family is very important, because the family caretaker could tell there is a sparkle in the eye and the person responds. And what we know from other studies, particularly from in care homes, is that very physical things can really improve living well, such as taking a leisurely bath and enjoying the physicality and the senses, and also enjoying food, or dancing together, even when language is no longer possible, taking people by the hand and dancing. Those are, the pleasures of the body become more and more important for living well.
Thank you very much, Dr. Gil. Third question is for Dr. Shoba, is do all people are prepared for telehealth, but are all doctors prepared for telehealth?
That's a very, very interesting question. The awareness in the medical fraternity, unfortunately, seems to be confined to the doctors or the rehab people, and it's very separate. So the doctors don't understand what it is, no offense. The doctors, as in the medical professionals, do not necessarily understand how the rehabilitation people actually work. So I am a speech therapist by profession. And when I run my clinics, it's always a live session. It's a one-to-one, one-to-one or with the caregiver kind of thing. And our sessions actually last an entire hour because we do rehab online. But for the medical professional, they don't have an hour with the patient. And our sessions actually last an entire hour because we do rehab online. But for the medical professional, they don't have an hour with the patient. They have 3 minutes at best. So their concept of going as an older person to a medical professional, the perceptions are very, very different. And then when they actually come to us, they love it. So the older person is ready for possibly rehabilitation and to do a lot of the therapy work, but not necessarily for the medical part of things. I hope that answers the question.
Thank you very much, Dr. Sharma. A question for Dr. Lian Watch regarding the HIV care in Uganda. Is it possible to live well with HIV? Is it possible to find a way to live well when you have an advanced disease? What do you feel? And even being aged and having HIV, do people feel different having the disease than not having the disease? You are mute.
Okay. Thank you very much for the questions. That is very surprise to us as well, because all of the data from the global north, we see that with HIV infected patients, their quality of life usually reduced. However, in Africa, when people receive the ART and they have the opportunity to live longer, as well as the interventions accompanied by different interventions such as a peer support, and also try to improve the economics as well. So when we compare the people in rural Uganda, the people who are infected with HIV seem to receive more interventions in order to improve healthcare access. So that's why when they live longer, they have the opportunity to have their quality of life. So that's why when they live longer, they have the opportunity to have their quality of life actually is better, because we think all kind of high blood pressures, the prevalence of high blood pressure among people with age actually lower than their counterpart who are not infected with HIV. And we assume that because a lot of people they may not go to the primary care early than people who are living with HIV when they receive the treatment from ART, and then they also receive the treatment for other health conditions. So that's why we see that kind of effects. And we plan to look at the prospective study design soon, because right now the data just for the baseline. But we are collecting the data for a second wave and the third wave as well.
Thank you very much, Dr. Quach. My question for Dr. Liu. Do young people think about how they're going to be when they are going to be aging? Do Chinese people think about that?
I'm sorry, can you repeat the question again?
Do young people, when they are children, think about how they're going to be when they are old? Or because
you mean when the adult children are young, do they think about being the caregiver for their parents?
Yes.
Yeah, I think the Chinese culture is Yeah, it's true. The young people, because those adult children, because when they are very young, they have they learn about that in the future they will become the main caregiver for their parents, and this is influenced by the culture of filial piety in China, and so they are socialized to become the caregiver, to take on the caregiving responsibilities for their parents. So in a quite young age, they will think about how to provide care, or some even feel anxious about it. And actually, in my field work, when I collect the data, they do have the interest in learning more about how to plan for their parents' future elder care. Yes.
Was your job done in a city or a rural area? Is it different in one or the other?
It's in a rural. It's in an urban area, but my participants are both the urban adult children and also include the rural adult children who have migrated to the city.
Mm-hmm. Okay, I don't know if you have a question for Ada, because we ran out of questions.
Thank you.
So if there are no more questions, thank you very much for your participation, and it was a pleasure to listen to your job, and hope most of it is going to be published. Okay, thank you very much.
Thank you very much.
Thank you. Thank you.
Bye-bye.
Thank you. Bye.
Bye.